Forget the right? And so by the end of the night, finally people were like, hey, what's your sugar? And he's like, I don't even care. And it's like, so then we actually had to start kind of babysitting his sugar levels as the night went on. And so it's that kind of, so there is the potential to, they can go really high and put them into DKA, or they could actually just, depending on the situation, depending on what they're doing with their buttons, actually drop. Okay. Infections, what kind of infections?
Sepsis?
UTIs are some of the big ones. Probably not gonna find that behind the wheel, but you have the potential. The other thing with this is that one of the things that's not on here is like an Alzheimer's, dementia, stuff like that. That can always lead to altered LOC with no real reason for it. Most of those patients, if you do end up with a dementia or Alzheimer's patient behind the wheel, what we start thinking is we actually start thinking infection on these ones. We're like, okay, elderly person behind the wheel, this is kind of weird, we have no other real reasons for it, and then we start thinking about that. So how are we going to tell if somebody has an infection going on?
Temperature.
Lung sound.
End tidal, right? So the worst. So assessment is the big thing on that, okay? Here are a ton of different things that can also cause altered LOCs, right?
Wait, what does end tidal look like with someone with an infection?
Low, drops low. So anything like below 25, you start to get concerned. And then we actually put in sepsis alerts.
Sorry, can you explain why it gets low?
Think about it. You explain to me. I'm excited to hear this. Why would you think it would drop? When somebody becomes septic, nasty infection.
So are they in metabolic acidosis, so they're not breathing as much?
Keep going.
So they're trying to compensate
How do we
their respiratory
treat?
system.
So what is their respiratory rate gonna do?
Increase, so you're gonna blow it off faster.
Okay. So you want to come up and finish your
Just
plan?
like,
See how easy it is? When
just
you
like
think about
DKA, because we're acidotic, we're breathing
it.
faster.
You're making an attempt, your body is making the attempt to regulate.
But when
right?
we
So
breathe
you're-
faster, our CO2 is gonna drop,
Yep, so your respiratory rate's gonna increase to try and compensate, which is gonna drop your
drop your CO2.
CO2.
And you're in metabolic acidosis because your white blood cells are fighting off the infection.
Yep.
So it's a metabolic thing, but you're compensating.
See this? At the beginning of paramedic school, you guys wouldn't have been able to figure that out, would you?
Metabolic
You guys are like, what was that?
What does metabolic mean?
Yeah.
We were almost done.
Almost doctors, you guys are almost there. All right, so a couple things that you're gonna look at as you go through your head injury stuff, right? Our GCS tells us a ton, correct?
Mhm.
What's the number that we look at the most with GCS? What's the big number?
Less
The
than
number
8.
that sends red flags out to
Less than
everybody.
8.
Less than 8
Less than
intubate.
9?
Always.
No. So Sarah just says if it's less than 8, don't intubate because she always intubates and it's always wrong. So that red flag, that less than 8 intubate, is a red flag. It tells you, hey, there's something wrong with the GCS. Figure out why. And a lot of the time, unless it's one of my scenarios, you end up intubating. But there are reasons that people will have a GCS less than 8 that don't constitute intubation. Does that make sense? All right, so the GCS started in 1974. Since 1974, that is the go-to pre-hospital LOC determination. It's all broke down. You guys are totally good with this, right?
Completely.
It's just hard to think on the spot. It is.
So, do you guys use the method of, okay, 4, 5, 6, you're adding up, you're like, okay, you got 4 here, and then you got 5 here, and then you got 6 here? Is that the method you use in your head?
Yes.
Okay? So just so you guys know, just to throw this out there, I do the opposite. I start with my 15, and I subtract. I'm like, oh, I lose 1 here, I lose 1 here, and I lose 1 here. I do the subtraction model, because It's like, oh, if I'm only to verbal, I'm like, oh, I lose 2 points there. What does that do if I'm not paying attention though? When I'm talking to other people?
It leaves you higher.
No, it leads me into, because most of the time when you give somebody a GCS score, you're given a 2, 4, 5. You're
Yeah.
given it in that method,
You
right?
can't do that.
If I start doing my subtraction stuff, sometimes I can end up getting myself with the wrong number in the wrong place. And it's just something that verbally I forget sometimes as I'm talking and stuff, and I'll get people confused based on that information. So you'll hear many ways on how to run through that in your head. Whatever way you use to keep it straight and that you can come up with it quickly is the important thing. Okay?
When you do your subtraction method, do you still keep track of how many you have in each box?
I do, yes. And so, but what happens is sometimes I'll flip my numbers, like when instead of saying 4, 5, 6, I don't keep them in that order every time. I go with, in my head, I'm putting the ones where I lost first, so it can get confusing
Why do you do
when I'm
that?
passing that information on.
Just-
Because he likes to be confused.
Because it's my way of coming up with the questions the numbers quickly. It's my method, because I wasn't good at,
Adding.
okay, the adding. I'm better at, I'm already at 15. I'm gonna be closer to the 15 most of the time than I am the 3.
Okay.
So it was my way of quickly getting to my number quicker, so. APU, you guys know APU?
Mm-hmm.
Yeah? You guys use that at all?
Yeah.
Is it underutilized?
Yeah.
It's absolutely underutilized. This is one of the good semi-conscious findings for people, right? So, because that's what we do on every trauma patient. What do we do up? We come up verbal, hey, can you hear me? No. And then down to painful, right? But then people document people's LOC as patient was alert and oriented times 4. ANO times 1, 2, 3, and 4. In documentation, it rarely gets documented as the APU, right? So the APU is very, very important when it comes to responsiveness in people that are semi-conscious or unconscious.
How do you document the alert, but they're disoriented, like, they're,
Well, that's when you go into your GCS now.
but not, because I had a patient in the hospital the other day, like, he was alert, and he was a stroke patient, he was alert, but he responded to everything that we did, he just couldn't respond back. So, he was fully alert, I mean, you asked him to do something, and he would, like, can you touch your nose? And he would touch his nose. Can you, I can't remember off the top, but he was
Okay.
alert everything.
He was
we
able to
did.
follow all verbal commands,
But he
but he
was-
couldn't verbally respond back.
Yeah, but he was also disoriented as well, so he wasn't like verbally responsive, or he wasn't just verbally responsive, like he was able to do stuff, but he was still disoriented, like he couldn't formulate, a proper thought process.
So was he responsive to voice?
He was.
Responded to voice, but
Yeah.
he appeared semi-alert,
Yeah,
semi-oriented,
yeah,
but not totally oriented.
yeah.
What did
like-
we just say it's A?
But it wasn't an A, but it wasn't an ANO times 1, 2, 3, or 4.
Yeah.
It was weird, I mean.
Yeah. So that's where, in that documentation, under your LOC section, that, in your narrative, you would basically explain that. You would be like, patient was awake, able to follow all commands, appeared semi-oriented, was able to follow this type of command, but when asked other simple questions, was unable to follow and was nonverbal.
Because I noticed that on our FISDAP, when I was doing the alert section, there's, if you click on A, it gives you the person, place, time, event. If you don't click any of them, it just says alert but disoriented. So it actually gives you that option in our FISDAP.
So with our charting, there's nothing like that, and so it all just becomes, and then even disoriented, so alert but disoriented, what does that really mean?
Yeah.
And so in our narrative, we get much more specific, and I'll type out a whole sentence, little dictation on trying to explain exactly what you just tried to put out there. Same kind of thing, so if somebody knows their name and knows how old they are, but they don't know what happened, like probably what happened with Mons, he's like, oh yeah, he blacked out, he doesn't even know what happened kind of thing. So he would be alert and oriented times 2, person and place, or person and time, but But then with that, I would follow up with, he was unaware of where he was, unsure of this, unsure of that, and just put in there to try and make sure that it was crystal clear on that LOC portion of it. So here we go, here's kind of the breakdown, so anything under 8 is bad. As you start to get into the 9 through 12, that's kind of your okay, something's up, something's not right. These are probably your close to severe concussion style. And then down here to 13 to 15, that just may be person's norm for them, it may be your Alzheimer's patients, or it may be like a mild concussion. All right, so we got 4, 5, 6.
When you give your radio report for your GCS, do you give the 3 sections of numbers?
Yes,
Every time?
yes,
So do you even give a total?
yes. So you give your number. So if it was 15,
Yeah.
then you'd be, I got a GCS of 15, 4, 5, 6. Exactly like that.
Okay.
And if
It'll
it
always
wasn't,
be in that order.
if it, yes, and that's where, I was explaining, that's why, for me, sometimes I get messed up because I flip my things around a little bit because of the way I do math. And so I have to stop and like think and be like, okay, which one's my I number, which one? So before I get my radio report, it takes me an extra second to do it. Like when I'm documenting, I can just do it real quick. Right? So the reason I'm coming up with my quick numbers for myself, it means nothing for what I'm passing on. It's all for my treatment and what I'm gonna do. Right? So whether or not I'm getting below that 8 number or what, if I'm at that threshold.
And you should be in the practice of calculating GCS for every patient.
Every patient, yep, yep. Because then when the time comes and you're super stressed and you have this kind of patient, GCS will just become natural. Okay. All right, decorticate versus decerabit, which one's worse?
Cerebral.
Right? So do they start off decorticate a lot of times and then slowly end up working their way to decerabit? Sometimes. If that's the case, that's a slow herniation, right? So most of the time, you're either going to present with decorticate or the decerabit. If somebody's decorticate, right, so they're coming to the core, can you pull their arms out?
Not usually.
Maybe you guys need to spend more time in the gym then. Sheesh, Dustin. Yes, you can pull their arms out, but what's gonna happen?
Yeah, go back.
They're gonna pull it right back. Is it gonna be an easy pull? No, it's gonna be a resistance. They're gonna resist against it, right? Because they're naturally trying to. Because if they're decorticate, if you say you can't move the arms, how are you gonna do IVs and stuff? Right? It's gonna be tough. So that's why you'll pull it out, you'll hold it there, you'll probably have to have somebody hold it, start the IV. Try not to go with the AC, because what's gonna happen?
It's gonna squeeze it.
Right? So this is where you can use like your forearm area are really good for these, not a 20 gauge. And so, just that type of thought process, because people will get into that mode where they wanna go with the AC, right? They're like, oh, we're gonna straighten this down, we're gonna do an AC. Doesn't do you any good if they're decorticate posturing, right? All right, so decorticate decerebate basically is flexed out. It's pretty crazy looking. It looks like somebody's possessed when they legitimately go full decerebate posturing. They'll arch their back, arms out, flexed out.
Will RSI take care of that? I mean, not necessarily take care of that in a
Right.
in
It'll
a
paralyze
positive
the
way,
muscles.
but it
It'll
will
paralyze the muscles.
we'll
yes.
get rid of it so we don't see it anymore.
Yes.
So we
I
don't.
just don't wanna look at it.
How do you document that then? How do you
What?
document that then?
So then it would be upon arrival, they were in decerebate posturing. After RSI, they lost their decerebate posturing.
Yeah, so it's very, very important, anytime you end up with somebody that's posturing, that information gets passed on if you eliminate that. Because then that speeds up that whole neurologist CT thing.
It's pretty common to find people kind of wrapped up in a fetal position, but if you speak to them and they can extend themselves out flat, do you record them initially as being, I guess, fluxation?
No, so decorticate and decerebate posturing are brain herniations that are happening. They are unconscious,
Okay.
right?
Okay.
So you're not gonna be able to talk to somebody unless they're having like some sort of like seizure or tumor that it's a chronic thing. If their posturing is gonna be based on the traumatic event, they're herniating, and they're gonna be unconscious on you.
Because we had a woman come in, it was a heroin overdose, we had to fight, like, multiple people fighting to get her out of the Victoria posture. That, she would just wrap right back into a ball every single
Right,
time we went over.
and that's basically by choice.
Okay.
So let's see. What do they score if they're decerebate on the GCS?
1, 2, 3. Decerebrate, 2.
Two.
2. See, so that right there, I went with my subtraction thing,
Yeah.
and I was just like, and then I was like, wait, no, I didn't do it with my subtraction. I know decerebrate's at the very bottom, it's the one right above. So so the way you come up with your method for figuring out your GCS, just be able to come up with it fast. How about the corticate?
3.
Alright, okay. So as you are assessing facial trauma, okay, how many of these are important to us?
All of them?
Good, right? So what method do you guys use to palpate the face? If it's anything like the way you use to palpate a femur, I'm very disappointed.
Usually like hand on each side.
Pressing down, like,
Where do you start?
all of the-
Where do you
Top.
start?
Top.
Back, top, move right now.
Okay, are we using our thumbs?
Yeah.
The thumbs are the primary thing that we're using. Why are we using the thumbs? Basically, I'm not gonna touch it, don't worry. Right? So as we're doing it, okay, so we start off on the back, right? We're pushing, right? Are we jamming, pushing hard?
No.
Or are we
Wide.
basically wide, like spreading out our surface area, right? Because we don't wanna push into, we don't wanna stick our finger in the hole, right? And so as we're coming around, right, we're pushing, we're feeling, shut your mouth, shut your mouth, dude, come on. Like every time, why is it, there's only one person that draws attention to it.
I didn't say a word.
So you said Raleigh did, right?
Yeah, so
Raleigh put his finger in the hole.
Raleigh stuck his finger in the hole. Surprise, surprise. I think he's here today, so that'll be fun. You should ask him about that, just without even leading into what we were talking about.
How'd the
So
hole
I heard you
feel?
stuck the finger in the hole. See how that goes, right? Okay, so as you're feeling, you're palpating, right? You're feeling for what?
Pepper this.
Anything bad?
Step off.
Okay,
You
so
can't be too
if you end up with something, a soft spot that's bleeding on the skull scalp part, how are we gonna manage that?
Direct pressure. Bleeding?
Yeah, with depression.
Not
With the depression?
Yeah.
Oh, and not
Direct pressure, here we go.
You just
Mark
said,
decided he
you
wanted
just
to
said
stick his finger in
bleeding.
the hole too.
You just said bleeding. You didn't say depression and
I
bleeding.
heard depression, yeah.
I didn't pay attention enough to hear you say depression.
Yes.
I just heard bleeding.
Okay.
Somebody other than me pumped.
Not paying attention to class, got it. Okay. I think today we may just have to pull out the
You gotta do it.
X series and see how well it works, right? All right, so we're feeling for those parts. So if we have something that's bleeding and we have a depressed portion of it, we're gonna lightly wrap it. Basically, what we're doing is we're keeping the blood from getting all over everything else. We're not really trying to stop the bleeding. If we happen to create a big enough coagulation, then great, right? Because if you think about it, if we were to pack this and somebody's bleeding with a depressed skull fracture, if we pack it tight and keep it from bleeding, what's gonna happen?
Increase size of the skull.
So you run the risk of having that blood end up in the skull, right? Which is then a brain bleed potential. Bad?
Yeah.
Right. So we're kind of okay with it bleeding out. Agreed?
Yeah.
Do we want it all over everything? Is it gonna cause more issues with blood just pouring out of
Yes.
somebody's head? So we do have to manage it. We do have to kind of bandage it a little bit. But so it's a light dressing, not a lot of pressure on it. right?
Absorption.
Do scalps bleed a lot?
Yes.
Yeah.
Do scalps swell a lot?
Yes.
Yeah.
Can there be major deformity from somebody that got hit in the head with something?
Yes.
I know, is there?
So,
So all my
okay, so if
PPE
you
on.
have someone with like a huge like thing right here,
A huge thing right
a
here.
huge massive swelling right here due to like, I don't know, hitting their head or something, how are you gonna, will you be able to tell if there's crepitus underneath that, or is it gonna be like, I feel like you wouldn't be able to push through.
The
Yeah.
swelling?
Yeah, I mean, basically it's a huge hematoma that has developed there. And so it's gonna be a big, soft, squishy,
So you won't really know if there's any kind of.
no, unless there's something obvious around the edges or something like that. If it's just a straight swelling under the scalp, it's gonna be really hard to tell if there's crepitus underneath there. So how easy is it to find somebody that has a laceration on the back of their head?
Easy, you're gonna
It
see.
depends on you, on his head, or like,
I was gonna say,
Full
so
of hair?
like for Noah, it might be kinda easy, right? For Mark, it might be a little hard, because are we there instantaneously? No? What happens to blood when it
Dry.
sits?
it,
You end up
Dries
with
and
this
gets-
big glob of stuff in somebody's hair. Usually it's wet, it's dark, and so then you're sitting there and you're like, hey, I'm having a hard time seeing here, and like, so what do you get to do? No. I like the idea. I like the idea, but no. we
They
don't
just
have-
heard it was me, so
They're like trying to get Mark's hair done, right?
Flush it with.
So it is very hard. You're gonna have to work through, because until you know what's there, you don't know if you can see straight to the skull. You don't know if there's an open skull fracture. You don't know what's there. No, that's why we have saline. We have saline. We just flush it, right? It's like giving them a free shampoo hair thing. Hey, we're gonna clean your hair. Wait, watch the bugs jump off it. Hey.
we know.
So,
we know
so
bees we get.
you're gonna have to figure out, you're gonna have to find inside, figure out what it is, figure out how bad the bleed is, because it'll look like a ton of blood, and then you look and it's like something small like that. Do those people need sutures or anything like that? Probably not. Some people, you'll open up and you'll be like, oh, hey, there's a little bit of blood here, and then you'll open up and you're like, I see a chunk of skull like this big, like, whew. So you're gonna need to have to go to the hospital. You're like, really? Do you think I need to go? I'm like, yeah. You might need a stitch or two. And I'm like, and your head put back together. And so I watch a lot of newer medics that are just like, hey, we're just gonna throw some 4x4 on around there and just try and absorb that, and just it's gross and disgusting. But you gotta look, you gotta figure out how bad the wound is, right? Okay. All right, so that's pretty much what we worked on the head. We're palpating all the way around. Then we move on to the face. Okay? So some of the main bones that we're looking at, we're checking the maxillary bone, and we're checking the zygomatic bone. Okay? So your orbits, right around your orbits, cheeks, okay? And your mandibles. Okay? So these are the big bones that we're checking for stability. That's really all we're really looking for, is we're looking for stability and symmetrics to it. Okay? So as you're using your fingers, you're pushing at the same time, right? Kind of like what we were doing here. So you can kind of rock back and forth a little bit if you feel crepitus as you're moving down with your thumbs. Okay? You're feeling the forehead, making sure there's no depression or anything like that. Because other than that, there's not a whole lot we can do for facial trauma. Agreed? Okay.
Do you ever reset a nose?
Reset a nose? No, we never reset a nose.
Okay.
What do we reset?
Tell
That's what we reset, okay? All right, you got your foramen magnum, right? Comes out the base of the skull. It's where your spinal cord goes. So we have a couple layers of the brain, okay? So you got your bone, which is the cranium, then you got your dura mater, and you got your arachnoid space. So with these, those are important to us because there are different types of head bleeds associated within these regions that will present differently, okay? So if someone was to create if they were to hit their head and they develop a bleed, inside the cranium, intact, all right, so it's a closed head injury, but it's above the dura, okay? So epidural, so if we have an epidural hematoma, an epidural bleed, okay? Because the epidural above the dura mater is very, very vascular, and is supplied by artery-style blood, okay? So very fast, high vascular, okay? So epidural bleeds are really, really bad for us, right? So this is basically, they hit their head, and now they have an open arterial bleed just pumping into this cavity between the dura mater and the cranium. So what would you expect to see with somebody like that?
ICP, Cushing's triad, altered LOC,
So let me give you a
headache.
Let me give you a scenario. So a kid is playing baseball, okay? You're out, and we're gonna say this is like high school level, okay? Pitcher takes a line drive off the side of the head, okay? Boom, kid goes down, right? Gets knocked out like Mons. Oh, you know, he wakes up 30 seconds later, oh, I'm good to go. Everybody's just like, oh, okay, right? Happens to be a paramedic there on scene, awesome. They go out there, they check the kid out, kid's able to walk off, he's sitting on the bench, he's like, no, I'm good. All right? Got a little bit of a headache, right? Probably, just took a liner off the thing. 20 minutes later, he's sitting on the bench, all of a sudden he passes out, goes into seizure-like activity.
Not so good.
Bad?
Yeah.
Real bad?
Real bad.
What's going on here? What happened?
Bleeding
That
got
bleed's
bad.
getting worse, the more pressure's building up.
So with epidural bleeds, a lot of times they will present with a lucid period or a lucid interval where they get knocked out, they wake back up, they're good to go, and then a short time later, they become unconscious again, right? Because what happened is they took the initial blunt force trauma, and there wasn't a whole lot of damage that happened, it just basically knocked them out, right? Got their bell ring. But then the damage occurred to the artery, and then now it's pumping blood into his brain, into the vault, right? Eventually, it gets to the point where it starts with the ICP, boom, out he goes, unresponsive. Are we gonna RSI this person? This person is probably gonna be intubated, right?
With
because-
lidocaine and fentanyl.
What's that?
With lidocaine and
With
fentanyl.
lidocaine and fentanyl, right?
And etomidate.
And that's why we're worried about concussions so much.
Exactly,
Because
exactly.
it could get worse.
Because
which I
concussions
know
can get worse. Well, what is a concussion?
It's that, what just bruising,
Banging
It's the
around.
first half of it without the ruptured artery,
yeah.
right?
Which
So
you
it-
couldn't tell.
Exactly.
Yeah.
And so that's where it's like, you can sit there and like, it used to be like, they're like, oh, you good? Yep, okay. I'm gonna ask you a question, and in a couple minutes I'm gonna ask you the same question, you gotta know the answer. Yep, okay, you answer it? Okay, get back in the game, right? That's what it used to be. Now, it's a whole different ballgame. Like, you're sitting out for weeks, you have to pass all concussion tests and protocols, which is awesome for kids, and like teenagers and stuff like that. So it's good for the generation because it was legitimately overlooked because the brain trauma, it's not an instantaneous fix, okay? And you do have to watch out for the long-term effects of the actual bleeds associated with it.
So if we go on season, we know the cause of the seizures, are we gonna try to treat the seizures with medication, or is that them having seizures just a natural reaction to
In a head injury.
that specifically?
So if you have a head injury, if you have that specific thing and they have no history of seizures beforehand, there's the treatment for those seizures is going to be the paralytics versus the Versed type of approach.
Say that again, please.
So if you go on this baseball player that is having seizures
After you got hit in the head.
after they got hit in the head and has no past medical history of seizures, the management for those seizures will more than likely be the paralytics, the intubation portion of it,
Yeah.
versus trying the Versed, because of the fact that you were able to think and realize, okay, yes, this was a head, this is what happened, this is what I'm thinking, this is probably more than likely an ICP. With that being said, would it hurt to try the Versed if you had time to be able to do that? You could probably try it, but more than likely it's probably not going to work.
Well, the percent idea is just that they're gonna come out eventually, and so they can breathe on their own. With this, there's no chance of them coming less out of it. I mean,
Well, so you can't say 100% that they're not gonna come back out of
Yeah.
this episode. It may be the fact that they're just going into this episode, they seize, and then like their body recovers a little bit, and then they're kind of awake. And so like, saying absolutely,
Yeah.
no, you're gonna do it this way, no, you're not gonna do it that way, you can't do that way at all. You have to kind of play it and be like, you know what, if I have time, I can try the Versed and see if it works, because then you can kind of not have somebody intubated, which is kind of beneficial, right? But knowing you're gonna end up probably having to intubate this person. Yeah.
Is this a good case for running TXA if you have a suspicion of what's going on in the brain?
You're not gonna give TXA if there's a close head injury,
Because you don't necessarily.
contraindicated.
I would avoid TXA in head bleed stuff.
Why?
Because the chance that you're gonna make the clot not get broken down by the body is high, and they're not gonna hemorrhage out in the intracranial space.
She just threw a dart from right field, threw him out at home.
TXA is only for hypovolemia.
I love TXA, I think it's the coolest shit ever.
All right, so we have our epidural bleeds. Those are really bad, right? So before we move on, let's go ahead and take a quick break. Stretch your legs, stretch your minds.